So what I want to do is then get to the stigmata. And really it becomes the discussion about the fat-soluble vitamins. So they're going to have steatorrhea. They're going to give you some footprints of a disease to get you to the steatorrhea, but then they're taking you on the fat-soluble vitamin deficiencies, right? So you have to be familiar with those. And we'll just go through these and get them on the books. So of the fat-soluble vitamins, vitamin E, I think, is the lowest yield of the bunch. You don't actually get a vitamin E level. You get a alpha tocopherol level. And what does vitamin E do? The big ticket item, sure, multiple things, but protects cell membranes against oxidative damage, whatever that means. So first of all, again, anything I just said can cause a vitamin E deficiency, but where I see them mostly buried is in the chronic pancreatitis, the kid with cystic fibrosis. That's where I seem to see vitamin E questions. And so if it's involved with this cell membrane protection, what are the cell membranes that get unprotected? So it's myelin. So you wind up, one of the manifestations are these neuromuscular symptoms. And again, with the boards, just be creative. Weakness, ataxia, paresthesia, peripheral neuropathy, anything that sniffs of neuromuscular is close enough, right? And again, it's all going to be in the right context. You know, they set you up with some disease that got you to vitamin E, and if they give you the neuromuscular symptom, probably it's going to be in combination with the red cell membrane. So intravascular hemolysis as well. So you have damaged red cells, you have neuromuscular symptoms. As far as hemolysis, you'll see this a million times. What are the labs? Haptoglobin decrease, right? Carries hemoglobin. High LDH, high indirect bili, reticulocytosis, and anemia. So hemolysis, the labs of hemolysis are all over the place. Be familiar with those. All right, so that is a vitamin E deficiency. Vitamin A, that gets good airtime. It's probably a little more complicated than vitamin E for sure. So what is vitamin A? First of all, you can get a vitamin A level, but historically you actually would just get a beta carotene level. So retinol from animals, beta carotene from plants. What does vitamin A do? This is the confusing piece, right? So it's involved with cellular differentiation. Think about the corneal manifestations. Phototransduction, we're all familiar with night blindness. That's easy. Don't hold your breath waiting for that. And this other issue of nonspecific skin benefits. So all the vitamin A deficiency questions have something about the skin, and it invariably is dry skin. There's something about flaking skin, right? So deficiency, vitamin A deficiency, has problems with keratinization, both in the eye and in the skin. So we anticipate vitamin A having some skin findings too. So just in terms of the clinical syndromes, right? So we already said there was problem with keratinization, keratomalacia, clouding of the lens, or these BTOT spots. And that's really how they're going to present. The nyctalopia, the night blindness, phototransduction, that's the easiest. But honestly, I just don't see them do a lot of that. When they say motor vehicle accidents, they're usually talking about things like pituitary tumors, or driving at night had an accident. It's still a pituitary tumor unless they give you something to go with vitamin A deficiency. And the other piece, this is what I just find confusing, and it's mostly, honestly, it's the Q banks. I don't really see it at the NBME. Failure of cellular differentiation. So you get the hyperkeratinization, dry, scaly, thickened skin, and the idea of, again, metaplasia. And it's, again, in the ducts, GU respiratory, ductal proliferation and dysfunction. So anyhow, there's this ductal piece of vitamin A you should be familiar with, certainly the skin and eye manifestations. Any of those disorders will get you to vitamin A, see it mostly with the liver. Vitamin A, where's it stored? In the stellate cell, the Ito cells in the liver. That's where it's stored. And again, you have abundant vitamin A stores. Where I see anything about the stellate cell, however, is that they actually convert into the myofibroblasts that are associated with the fibrosis of the liver. Vitamin K deficiency, big. Vitamin K is big, right? So what is vitamin K? There's gamma carboxylation of clotting factors. So our clotting factors are inactive until they become activated. Certainly there's a coagulation cascade. We have to activate clotting, but you first have to activate the clotting factors, and that's the gamma carboxylation of the inactive factors. So first, where does vitamin K come from and where you're going to see it? So it's this idea of the hemorrhagic disease of the newborn, right? Kids are injected with vitamin K when they're born because their liver is immature and they don't have bacteria in the gut yet. That comes later, right? So you need the endogenous synthesis from gut bacteria. And really one of the classics, well, you're in the ICU, you got myriad courses of IV antibiotics, all of a sudden you're bruising from everywhere, your PT, PTT are going up. What's happening? You killed entire flora, you're not synthesizing vitamin K anymore. So these are going to be a couple of vignettes where, unusual vignettes where they might come after you with vitamin K deficiency. The real vitamin K story, yes, same thing, chronic pancreatitis. If they talk about a patient with chronic pancreatitis and bruising, it's vitamin K deficiency. They talk about a patient with Crohn's disease and bruising, it's vitamin K deficiency, right? That's what they're talking about. But most of your vitamin K questions are going to come related to the use of warfarin, right? Blocks vitamin K, right? So again, you have these inactive factors that need to be gamma carboxylated to the active factors. Then we have the cascade. Vitamin K has to be reproduced, right? It gets oxidized, got to be reduced again. Warfarin interferes with that step. Vitamin K epoxide reductase inhibitor. But again, the questions really are how they describe vitamin K, and it's again the agent involved with the gamma carboxylation of clotting factors. So the clinical syndromes, of course, are bleeding or bruising, right? That's easy. And I just want to mention, so we'll come to this when we do hematology, but in terms of the classic labs, so we're familiar with the prothrombin time, PT, INR is used to measure warfarin therapy, but if you're looking for vitamin K, it's really about the prothrombin time, which reflects vitamin K. What are the vitamin K dependent clotting factors? 10, 9, 7, 2. So factor 7 is a vitamin K dependent factor, short half-life. It's measured through the prothrombin time. Typically, patients on warfarin, you would not get elevation of the PTT. So 10, 9, and 2 wouldn't necessarily be affected by warfarin. But if you take too much warfarin, they're all vitamin K dependent factors. So the PTT can go up, does go up. They ask that question. I'll be asking that question during hematology. So just be aware too much warfarin is also going to affect 10, 9, and 2, not just factor 7. And the other thing about warfarin questions, and again, we'll do this during hematology, but these are deficiencies of clotting factors. So when you're studying these patients who are vitamin K deficient or took too much Coumadin, you can expect they're going to ask you the results of a mixing study. Mixing study, we're adding back normal clotting factors. So a patient who took warfarin or vitamin K deficient, you add normal plasma, the bleeding abnormalities, PT, PTT will normalize. So you'll see mixing studies involved with vitamin K questions too. What you won't see are abnormalities of the bleeding time, right? So these are just classic vignettes. And again, not to beat it to death, we'll do it during hematology, but just remember bleeding time is about platelets. So if they have a patient with bruising, bleeding, and it's a setup for a vitamin K deficiency, you're going to have to decide what the bleeding time showed. Normal. There's no problem with platelets. This is about clotting factors. So those are the big ticket items. We talked about the predisposing demographics. We talked about the clinical presentation with vitamin E, hemolysis neuromuscular, vitamin A, squamous metaplasia, ocular symptoms, vitamin K, coagulopathy, gut flora, which leads us back to this. Vitamin D. You remember vitamin D from the calcium lecture? So here we are at vitamin D. That's why this one comes next, right? What does vitamin D do? We said that it increases calcium absorption. It does so by increasing the binding protein, calbindin. And ultimately, you're absorbing calcium, and that's where you're getting the bone benefit. Are there vitamin D receptors on bone? Sure. Are they big ticket items? Not really. For us, it's mostly vitamin D has to do with normalization of calcium. Remember this slide too? So this is where it was. So we talked already about low vitamin D and the effects on bones in end-stage renal disease. And we just went over, again, the steps in fat absorption that brings us to these diseases of the bone, rickets, osteomalacia, fractures, etc., bone pathology. And that is stuff we're going to cover during MSK just to bring the whole thing full cycle. In terms of introduction, I've mentioned osteomalacia. Osteomalacia, if you're not mineralizing bone, remember osteoblast, lay down osteoid, right, which is collagen, and you get cross-linking of collagen. 2 weeks later, it's mineralized with calcium. Well, if you don't have calcium, you can't mineralize it. So you have these wide seams that are described in osteomalacia, unmineralized bone, insufficiency fractures. Rickets, let me just say this about rickets. Again, we're going to get there, but bone synthesis, you have this normal palisading of chondrocytes that will ultimately break down, become mineralized, form bone. You need vitamin D to break down chondrocytes that ultimately become bone formation. And people vitamin D deficient, the chondrocytes don't die. You wind up with this disordered bone growth. We're going to cover it in bone. All right. So, right, everything all ties together here. We'll cover these in bone. That is it on fat absorption. Again, it's just a big ticket item. You see that it went to all different organ systems. And I feel like I needed this as a prelude before we get to bone down the road.